So, good evening, everyone, or if you're somewhere else, perhaps good morning or good afternoon. I'm very happy that you're today joining the webinar on pharmacological optimization of lung cancer treatment. My name is Rob ter Heijnen. I'm a hospital pharmacist and clinical pharmacologist at the Radboud University Medical Center in the Netherlands. And I'm very happy that today we have a very diverse program on pharmacological optimization. So, first, we'll touch on drug-drug interactions between small molecule inhibitors or targeted therapy with direct-acting oral anticoagulants. Then next, we'll talk about therapeutic drug monitoring, whether it's ready for the clinic or not. And last but certainly not least, the ESMO clinical practice guidelines for management of toxicity from immunotherapy are discussed. And we'll round up with a Q&A and thereafter the webinar will be closed, but all material will still be left for those who want to study afterwards. So during the webinar, you can submit your questions live through the Q&A widget, and after the 3 lectures, then there's a possibility to discuss them. You can chat and connect with your colleagues through the meeting hub, and if you have any technical difficulties, then you can click the live support icon for technical assistance. So our endorsers today are Longkanker Nederland, which is the Dutch patient organization for lung cancer patients, and longoncologie.nl, which is a website on lung cancer medical news. So the chairs today will be me and also Marcus Jurger, who is a medical oncologist from Switzerland, and will be also chairing the Q&A afterwards. And Marcus will also discuss the role of TDM in management of lung cancer. So those who have joined, you're pioneers, so this is the first webinar on pharmacological optimization of lung cancer treatment, and so we really value your feedback. So you really help us with filling out the post-webinar survey after the program, and a certificate of attendance will be sent by email upon completion of the survey. So you can even get your CME accreditation points, and in total you will receive 1. So we'll start out with a lecture by Laurens van der Linden, who is a pharmacist, PharmD and PhD at the Catholic University in Leuven, Belgium, and he'll be discussing the drug-drug interactions between small molecule inhibitors with directly acting oral anticoagulants in patients with lung cancer.
I have the honor and pleasure to give the first session today. I'll be discussing drug-and-drug interactions between small molecule inhibitors, SMIs, with direct-acting oral anticoagulants, DOACs, in patients with lung cancer. These are my disclosures. But my goal now is to take you on a journey so that these conclusions here on the right side of this panel will make sense to you. Assess, avoid, and follow up. And we'll have to get there in 15 minutes, no less. 15 minutes. We'll be able to do it perfectly. So first, I'll focus on cancer and lung cancer specifically. Cancer, as we know, confers an increased thrombotic risk. There's a clear causal link explained by a prothrombotic state. In cancer, each of the 3 components of Virchow's triad that predispose for thrombosis have some abnormalities. For instance, many procoagulant factors such as tissue factor are increased. These mechanisms are likely to be multiple and synergistic. And this prothrombotic state leads to an increased risk of symptomatic VTE, such as deep venous thrombosis and pulmonary embolisms. In lung cancer, this increased thrombotic risk translates into an annual VTE risk of about 14%. This is high, as you can see here in this graph, with data from a large claims database analysis from the US. Importantly, we think thrombosis, so we think about anticoagulation, but there might be some issues. There is a reduced protection by anticoagulation. Here we see data from a prospective follow-up study where they found that cancer was associated with an increased risk of recurrent VTE among those who receive anticoagulation. You can see here on the left panel. On the right panel, you can see an increased risk of major bleeding among those with cancer compared to those without cancer. So in sum, and this is the first bit, lung cancer is associated with an increased risk of de novo VTE and an increased thrombotic and major bleeding risk among those who receive anticoagulation in the management of said VTE. For cancer-associated thrombosis, we surely need to give anticoagulation. Anticoagulation is indicated, and DOACs are a very appropriate option. And this is also recommended explicitly in multiple clinical practice guidelines. The latest ESC guidelines correctly state that apixaban, edoxaban, rivaroxaban, all 10A inhibitors receive a 1A indication in this setting if there are no contraindications. And they do draw our attention to so-called major drug-drug interactions where low molecular weight heparins might still be favored over DOACs, over these three selected DOACs. So also here a short summary. DOACs are non-inferior to the standard of care, the low molecular weight heparins. There is a signal of improved thrombotic protection, but there might be a price to pay regarding more bleeds. And we should take into account major drug-and-drug interactions, which is, of course, the main topic of this talk. First, drug-and-drug interactions are so prevalent in the cancer setting that the American Heart Association has put out an excellent review paper on this topic, how to manage these interactions. I highly recommend this paper. It's very nuanced and rather complete, actually. There are, of course, many potential drug-drug interactions in the domain of cardio-oncology, and here we'll focus on those related to NOACs, specifically in lung cancer, where the SMIs might impact DOAC exposure. So the SMI is a culprit, and the DOAC might be a victim drug. Here, I'll be using these 4 steps to give a sort of helicopter view on how to approach drug-drug interactions with SMIs and DOACs in patients with lung cancer. First come the basics. The ME, absorption, distribution, metabolization, and excretion, absolute basics. And very briefly, you have these 3 DOACs, or NOACs, with data in cancer-associated thrombosis. I'd like to draw your attention here to the right side of the slide. All of them work fast. They work rather short as well, and then you arrive quickly at steady state. And similarly, within 2 days of stopping DOAC, most, if not all, anticoagulant activity will be dissipated. And all of them undergo some degree of renal elimination. In that sense, you can consider them to be rather oral analogs to low molecular weight heparins. They kind of work the same way in our body. And these DOACs have a much lower drug-drug interaction potential compared to vitamin K antagonists, for sure, but it is not zero, particularly if you compare them to low molecular weight heparins. To different degrees, these DOACs are substrates to several enzyme systems, channels, proteins, and here I'll focus on the CYP enzymes and P-glycoprotein. But what does this now actually mean? What does this convey in the setting of DOACs? Well, this is actually quite straightforward. Exposure will decrease in the presence of inducers for all 3 of them. A strong pan-inducer is rifampicin. The exposure will increase with the use of strong dual CYP3A4 PGP inhibitors for apixaban, rivaroxaban. Typical dual inhibitor is ketoconazole, and for edoxaban this will occur in the presence of strong PGP inhibitors. A typical inhibitor that might be relevant in this setting is cyclosporin. This is also what we can recognize in the package label of these selected DOACs. It's quite explicit, actually. So here you'll notice already that SMIs are not included in the package labels. And as a rule, the DOAC will not influence the SMI, but the SMI can act as an inducer and or inhibitor and hence impact DOAC exposure. But how to deal with these SMIs then in this specific setting. Well, it might be interesting to take a look here at guidance from the FDA and EMA on how to interpret the relevance of a given drug and drug interaction. And they consider a drug and drug interaction strong in the case that it confers more than a 5-fold change of the area under the curve, moderate in case of a 2 to 5-fold change, and weak if it's less than 2-fold. For example, here we see a graph of apixaban exposure. On the x-axis, you can see the AUC ratio of apixaban taken together with a specific agent versus apixaban alone. And the one above is ketoconazole, which it doubles the AUC of apixa and is relevant. And this is rather a conservative approach, or a simple, very straightforward, not really nuanced approach. Doubling or halving of exposure is actionable. And again, this is what informs the package label, and we can recognize this. We do have some trial data on what happens when we actually double the dose, and the bleeding risk will go up. It is then increased by up to approximately 1% when you double the dose. Einstein Choice, Amplify Extended were extension trials in the VTE setting, and secondary VTE prevention engaged TIMI-AF. 48 was the landmark trial of edoxaban in AFib. Okay, so besides this framework, trial data might also be informative. First, we have some good news. Most interactions are not clinically relevant, so that's a good thing. But then, of course, the practical news, we could take a look at the actual trial protocols. SELECT-D with rivaroxaban and Caravaggio with apixaban did not provide real explicit guidance on how to deal with drug interactions. And in Hokusai VTE cancer, well, the protocol did stipulate how to dose edoxaban in case of certain co-medications, as detailed here on the slide. But now, when we take a closer look here at Caravaggio, only selected drugs were excluded, so it's an exhaustive limited list. And as a result, many potentially interacting agents were allowed, and these included potentially interacting cancer therapies. In a post-hoc analysis, the influence of these potentially interacting co-medications was investigated on multiple outcomes. And as you can see here, for recurrent VT on the left, major bleeding on the right, there was no real impact associated with the use of these interacting agents. It's actually quite reassuring. And similar results were retrieved for death from any cause and event-free survival. Also reassuring. So in sum, there was no signal of any harm for any of these endpoints when taking CYP, PGP inhibitors, or inducers together with apixaban in the setting of cancer-associated thrombosis. But, always a but. Such analyses are reassuring for sure, but there are some limitations. About 25 had lung cancer in Caravaggio. A little bit more than half of all patients received active chemotherapy, but actually only a very small number of patients received targeted therapies, received small molecule inhibitors. So it was limited. So again, while reassuring, we cannot really draw strong conclusions regarding specific therapies. Perhaps plasma monitoring might help us to interpret the impact of these agents on DOAC exposure. And here I've tried to give you the shortest possible summary on how and why of fixed dosing that we follow for DOACs in clinical practice. There is a clear relationship between dose and plasma exposure, at least in phase 1 and 2 studies. And this plasma exposure, again in a linear manner, is linked to pharmacodynamic effects. They went then ahead with fixed dosing phase 3 studies, but other things came into play. Patient characteristics do not only impact the dosing and the exposure, but also outcome. Moreover, post-hoc on therapy ranges were retrieved and documented, but they were very broad, and they were based on limited sampling performed as part of set phase 3 studies. And given the clinical results attained with such broad ranges, some argue that with DOACs, we might have end up with a sweet spot. And taking all of the above together, I propose to you now a pragmatic framework. So we have seen that DOACs behave like low molecular weight heparins with a high propensity for drug-on-drug interactions, depending on the DOAC. Most therapies do not lead to a doubling or halving of steady-state AUC and are actually allowed. Clinical data up to now are rather reassuring, and plasma monitoring might have a place, but we should refrain from over-interpreting these data. So what would now be a feasible, pragmatic approach? And here on the left, you can see the proposal on how to think about, how to assess, how to select anticoagulation in the setting of cancer-associated thrombosis as recommended by the European Society of Cardiology. On the right, I've added some very basic steps to help professionals. And step one is think and assess, consult with an expert. Please use good software prescribing software and consult valid databases. Step two, well, we should be reassured that there are many drug-drug interactions and most are not that relevant. We could draw inspiration from the FDA EMA framework. For example, if the impact is less than twofold, most likely it's not that relevant, and otherwise it is actionable. You should do something, and here I'd argue to select an alternative, for example, another DOAC with fewer drug-drug interactions or a low molecular weight heparin. And then step three, try to keep using these tested doses, refrain from adjusting doses based on solely pharmacokinetic data. We can and sometimes should probably measure exposure, but mostly to exclude over and under exposure. And of course, therapy should be evaluated periodically. Regarding those databases, I'd like to add that all published work is easily dated. For example, you can see here the table from the ESC guideline, not interactive, no background literature, difficult to use. What then to use? Well, you have multiple options, for example, the DDI manager as seen here. I've added some additional nuance, but this is just additional information. Most importantly, also take into account the limited time, I'd like to go to the take-home messages, particularly now that all of us can understand these three main conclusions. We should assess and consult. We should avoid situations where the exposure is doubled or halved. Follow-up should be provided, and if need be, we can measure to exclude over or under exposure. I thank you for your attention.
So that was the lecture about direct oral anticoagulants together with targeted therapy. For the next session, we'll go over to the lecture by Marcus Jöger on therapeutic drug monitoring of small molecule inhibitors in patients with lung cancer. Are they ready for the clinic? So I'm looking forward to this lecture.
Hello everybody, my name is Marcus Jöger. I'm medical oncologist at St. Gallen Cancer Center. Very happy to discuss with you some aspects of therapeutic drug monitoring in patients with, I would say, mainly advanced lung cancer. Ready for the clinic? So I hope you're ready. We can start. These are my disclosures. So what are the indications or preconditions for doing TDM? There is a set of preconditions that I think is very important that we consider and realize that. So it is obviously for drugs that have a narrow therapeutic window. This is probably basically all anti-cancer drugs, I would argue. High variability in oral absorption. Here we are talking more specifically about the kinase inhibitors. That is the topic of today, or at least of my talk. Importantly, inter-individual variability in PK should be higher than intra-individual variability. This is usually the case because, of course, inter-individual variability adds on intra-individual PK variability, but may not never be the case. Increased risk for DDIs, drug-drug interactions, or polypharmacy. That is certainly a check for the kinase inhibitors, maybe not necessarily for all anti-cancer drugs. A very important, an established PK target range and dose exposure relationship. We will see this later. This is I think an important criterion. Potentially special populations. So I will also touch a little bit on you know, like general TDM situations or opportunistic, I would call it opportunistic TDM, where we could focus maybe on special populations, for example, patients with organ dysfunction, or in our case, with kinase inhibitors, GI malabsorptions. Cumulative long-term and or irreversible toxicity. So at least the cumulative toxicity has been a recent topic of growing importance in oncology. You all realize that this was somewhat different with chemotherapy, not totally different, but particularly with the kinase inhibitors, we realize how important it is to differentiate between acute toxicity and cumulative long-term toxicity, which is an important reason that over many years and probably still the phase 1 trials somewhat overestimated the recommended dose, and this is also a base and had as a consequence FDA's Optimus program or project that asks for randomized dose optimization trials. Lack of early predictors of activity. This is certainly something that that is usually the case for our patients, for cancer patients. So let's switch gears. So I was involved with many of you probably in some activity, writing also white papers. My expertise was more in the chemotherapy field. And of course, within these groups, we considered very heavily what is good guidelines to apply for TDM in oncology. And colleagues from the psychiatric field published some guidelines on TDM. So they are going a little bit ahead because there in Psych 3 you have many situations that use TDM. And here 4 levels of dosing recommendation of TDM recommendation. You can see strongly recommended level 1 here. The guidelines ask for controlled clinical trials. It's of course very important. Then level 2 would be established exposure activity toxicity relationship. So I think today probably this is still valid. Of course, there is a lot of discussion. Early work, but what do we need as a basics before we go into validation of TDM or building up clinical trials? So we need a PK/PD model because that's a precondition to establish a therapeutic range. A bioassay, of course, we already mentioned that. And then the big question is, should it be controlled clinical trials? Today, there is a lot of discussion about synthetic comparators. Of course, reducing financial toxicity can be an endpoint. It has not, in my opinion, to be necessarily the improvement of clinical activity. So I already mentioned this. I think we should differentiate a little bit between routine versus opportunistic TDM. And opportunistic TDM for me would be particularly special populations like patients with organ dysfunction, increased DDI risk, frail patients, patients that already have experienced severe toxicity where TDM could help to get more insights on the problem. Patients lacking expected activity thresholds, that's of course a difficult one because usually there we look at alternative treatment options and are tempted to switch treatment rather than to look at potential underlying pharmacological issues. Suspected compliance may be an issue. High pressure for tumor response, I think that is something that could become more important in the futures, in particular also in lung cancer, where the kinase inhibitors move to neoadjuvant regimens, and there we have of course a pretty high pressure to achieve a good response. So I will only touch on basically on two groups of kinase inhibitors, the EGFR inhibitors and the ALK inhibitors. Here you can see the group of EGFR inhibitors. Actually, the title is not completely correct because I recently added monoclonal antibodies, antibody-drug conjugates that are also EGFR inhibitors. So the title is still the old title. I wanted to show this table also because we have to realize, and you are certainly aware of that the therapeutic field moves, and with compounding the data for recommending or not recommending TDM, we of course always run a little bit behind the therapeutic field. And currently osimertinib is used. That may change. I will not go into that, but just that we realize that this is really a moving field. So what do we have for data for osimertinib? There is Japanese data, Japanese colleagues that established somewhat a PK target range. Here with the advantage of the kinase inhibitors is that you can pretty easily use the trough levels. And you may not even necessarily have to very stringently go for C trough, which has to be taken at steady state, obviously, before next dosing and usually in a fasting condition. So the Japanese colleagues, they established some correlation of exposure or C trough levels with either activity but also some skin toxicity. This is not so unexpected because from the first generation EGFR inhibitors we also already knew that there was at least a dose skin rash association. You can see for the second small trial, please consider the small patient numbers, there was some correlation with high and low exposure patients. This was not seen with overall survival. Then the group of ALK inhibitors, this is also a moving field. There are currently 3 very potent ALK inhibitors that at least have an FDA approval for first line. So experts in the field are discussing at times the value of one ALK inhibitor over the other one. In Europe and also in Switzerland, we usually still use alectinib in first line. And then the field is open for second line briga or lorlatinib. Just to show the group of ALK inhibitors, what do we have for pharmacological data potentially working towards TDM? Here, I think clearly we have the strongest data for an exposure activity association or relationship for both for alectinib and brigatinib, the 2 probably most frequently used ALK inhibitors. This is a work from our Dutch colleagues that looked in a moderately sized patient group, criso plus also alectinib, and they looked at the trough levels for both drugs and importantly, they did random random sampling, and they calculated the C-min based on a formula, so and on the average population clearance. They used this dosing algorithm that I'm showing here to achieve a minimal C trough levels. You can see here that importantly there is a wide variability in the plasma concentrations. That's something we know very well. You can see here this for criso and also for alectinib. And then in particularly for alectinib, there is a pretty good separation for the PFS curves for C trough levels, high versus low. And this is pretty intriguingly also some separation for criso, but not that impressive then for alectinib. And this actually was the base to go for a prospective randomized trial that is ongoing at the moment. Also initiated at least from our Dutch colleagues. I think some French centers have potentially joined the trial. ADAPT-ALEC, a very nice initiative that has to be applauded, a prospective randomized trial that compares standard dose of alectinib, so 600 mg BID versus a TDM that intends to achieve a minimal C trough level of 435 nanogram per mil. Also with probably the same dosing algorithm. And the primary endpoint of the trial is median progression-free survival, a pretty large trial. So this is an initiative that has to be really applauded. Now, very shortly, some data on brigatinib. There we have also positive exposure activity data. This was first shown in a pivotal clinic, in data from a pivotal clinical trial, the ALTA trial that used 2 doses of briga in patients relapsing on crizotinib. This was done by the manufacturer, by Takeda, and Gupta and colleagues have showed that there is a correlation between the steady state C trough levels of briga and PFS, and also OS, and also an association with skin rash. These data also were the base for the step dosing, where investigators have seen that if you do the step dosing, that you can ameliorate some of the toxicities. And these data have been taken as a base for a pretty extensive simulation trial also from our Dutch colleagues. They simulated patients in 4 dosing regimens, so the approved 180 mg, the MTD dose of 240, and then 2 groups that targeted a median C trough for 180 OD or 240 OD. And this simulation trial, important, that's an in silico trial, but they showed that by the simulations you could improve PF and OS when moving from the label conformal dosing to group 4. And the average brigatinib dose was increased in this simulation trial by 70%. Here you can see that if you apply TDN again in simulations, not unexpectedly, you see that the variability decreases. And this is lastly, just to touch very briefly, of course, there is not a non-important subgroup with BRAF mutations in NSCLC, where there is an indication, at least in our country, for I think only dabrafenib and trametinib. There is not a lot of data, but again, our Dutch colleagues looked looked retrospectively at a pretty extensive group, all patients with advanced NSCLC, and they looked at those 4 protein kinase inhibitors, and they took the patients with the 10% highest trough levels and looked whether there was an association with toxicity. There was one, but only for alectinib. You can see here clearly the red bars are the patients with higher concentrations. This was not found for the MEK or the BRAF inhibitors. And just to finalize, I think I have probably one more minute. One case vignette. There are several case reports in the literature, particularly with osimertinib. So I thought I would show a known one. We do opportunistic TDM in those patients. We unfortunately don't have yet a systematic program. This is actually a female never smoker patient from the Netherlands, which lives here, presented with EGFR deleted lung cancer. She had to have initial surgery for her spine with denosumab. We initiated OSI at the approved dose. She had some skin toxicity, which got a little bit into cumulative problems. We did TDM. We found a trough level that was pretty comfortably above the target range. We reduced to 40. The patient was still moderately above the target range. Then she developed a PD after an average okay time for osimertinib. We first, we took a rebiopsy as we usually would. We detected the c-MET amplification. We first tried to dose re-escalate OSI, and as we would probably expect, we were not able to salvage her because you can see that already with the 40 mg she was above what we would consider the target range. So we had to salvage her using radiotherapy, and we were able then also to add a MET inhibitor because she had this amplification. She had a minor response. Later relapsed again locoregionally. We had to switch her to a pretty toxic triple combination where she had some, or most patients get some pretty challenging skin toxicity. We are managing that. We are still going on. She has a very good local control, recently developed brain met, which is undergoing a stereotactic radiosurgery. So just to illustrate you a little bit the complexity, and I think a pretty nice case where we have where we found some opportunistic indications to do TTM, which I think helped the patient and was very useful. So my conclusions, outlook: the rationale for TDM is compound specific, clearly in my opinion, and still remains for the foreseeable future, and it's based on the on the presence of a reasonable exposure activity toxicity relationship, very important. The second point is certainly food for discussion. Regulatory bodies, I think, should consider approval of a pharmacological PK target besides a specific dosing regimen for drugs that fulfill the basic conditions. This is not yet the case, but I think is more and more discussed by FDA and also EMA. Dosing optimization is enjoying increased momentum and popularity. I think that's also very important since the introduction of FDA's Project Optimus. And I recently was able to join a very interesting discussions of the cancer medicines group from ERTC together with EMA, where this dose and treatment optimization was vividly discussed, and I think it's a good time to move the field forwards. And with that, I hope that it took me not too long, and I'm very thankful for your interest. Thanks for joining.
Thank you, Marcus, on this insightful overview of the potential role of dose optimization in lung cancer. I think it's time to move on to our next topic, which is presented by Caroline O'Leary on the management of toxicities from immunotherapy. Looking forward to it.
Hello, everyone. My name is Dr. Caroline O'Leary, and thank you very much for inviting me to speak today. I'm currently working as a specialist oncology registrar in Ireland with a special interest in immunotherapy in the treatment of cancers and the treatment of immunotoxicity. And today I will be presenting on the management of toxicities using the ESMO clinical practice guidelines. So these are my disclosures. So I've used a case to frame the structures here just to illustrate some of these points. So a 75-year-old gentleman initially presented to the oncology department in December 22 and had a massive, rapidly growing mass over his right mastoid. He had a previously resected scalp squamous cell carcinoma removed in November 22, so only a month before, but unfortunately then had recurrent multiple areas of squamous cell carcinoma extending down his posterior neck with large swellings, and a biopsy proved that this was a cutaneous squamous cell which had metastasized to the lymph nodes. CT next confirmed large involvement of lymph nodes, but no distant metastatic features. For a 75-year-old gentleman, he was in relatively good health, but unfortunately had a very significant history of ischemic heart disease with multiple stents and a previous myocardial infarction. And this made us reluctant to use chemotherapy as a first line due to the high risk of complications. He was otherwise a healthy man, never smoked, never drank, did have slightly poor glycemic control, which unfortunately was made worse, but I'll go into that later. This is an illustration of the patient's neck on first presentation, and this was a very rapidly growing mass, which was obviously starting to ulcerate around the back, so very, very difficult for the patient and his family. He was commenced on nivolumab, which is an immune checkpoint inhibitor, and started this every 14 days from February 23. He had a couple of small complications, admitted post-cycle 2 for an infection and acute kidney injury, and had some issues with myalgias and joint pains for which he was started on a low-dose steroid. He had ongoing deranged blood sugar levels for which he attended the endocrinology department. However, come December 2023, nearly 12 months after starting treatment, he was noted to have an almost complete resolution of his disease. And as you can see here, there's a huge improvement in the disease mass. The patient himself was clinically much improved. So the development of immunotherapies and the use of the immune system in fighting cancer is not a new concept. Back in the late 1800s, William B. Coley just noted that patients who suffered from erysipelas seemed to have an improvement, or one specific patient seemed to have an improvement in his sarcoma following recovery from erysipelas. When he then induced an immune response using erysipelas in other patients, he noticed a reduction in tumor bulk also. However, his findings were not widely accepted, and the use of the immune system fell more or less out of use until the discovery of far more detailed understanding of how the immune system works, in particular T-cell development and its uses. The recognition and discovery of specific immune checkpoints, in particular PD-1 and CTLA-4 in the 1990s, opened the way for the development of specific immunotherapy drugs, which target these specific receptors. So the targeting of CTLA-4, first drug, ipilimumab, was only approved in 2011, with the first PD-1 drug, nivolumab, approved in 2014. So these drugs are extremely new and novel, but have rapidly started to be used in all aspects of treatment of chemotherapy. As a result of these findings, Dr. J.P. Arisen and Tasuku Hanjo won the 2018 Nobel Prize in Physiology for the innovation and influence of these discoveries on cancer treatment. So when we talk about immunotherapy, it can involve any forms of treatment which are involving the immune system. So these can include cancer vaccines, or adaptive cell treatments. But most commonly when we speak about immunotherapy, we are talking about immune checkpoint inhibitors, and it'll be these category of drugs that I'll be focusing on for the rest of these talks. As you can see from the list here, hopefully some of these drugs are familiar to some people. There's a range of CTLA4, PD1, and PDL1, which is PD ligand drugs developed, and more and more being approved every day for use, or every month. So the structure and the basis of these drugs is the immune checkpoint regulatory pathway, which is part of the system of checks that the immune system, in particular the T cell, uses to recognize own cells or non-pathological cells from pathological cells to be destroyed. Now, tumor cells have a way of inhibiting the T cell recognition of it as an antigen, in particular using CTLA4, which is cytotoxic T lymphocyte-associated antigen 4, and PD1 or PDL1, which is the ligand, which is programmed cell death 1. And again, these are the two main domains the drugs we use focus on. So the mechanisms of action for both of these drugs are relatively similar. Tumor cells develop a PD1 ligand, which then binds to the PD1 domain on the T cell. This inhibits the T cell, prevents it from recognizing the tumor cell, and prevents it from destroying the tumor cell and activating. So by blocking the ability for PDL1 to bind to PD1, the tumor cell recognizes that the tumor cell is immunogenic and will destroy it as it would any bacteria or other pathological cell. In a similar way, CTLA4 blockade uses the B7-1 and B7-2 domain to bind to CTLA4 on T cells, which again prevents the T cells from activating and destroying the cell, while blocking the B7-1 and B7-2 with the medications we have available allows CTLA4 to bind, and T cells were then able to kill the tumor cells. So as you can see here, there's a wide range of different immune checkpoint inhibitors approved for use across a range of cancers, and the concept of tumor agnostic treatment is becoming more and more prevalent in cancer, where one drug can work on a range or possibly all the different cancer types. These can be used in a number of different structures also, so either as a monotherapy, which is used commonly in lung, is a dual therapy with another immune checkpoint inhibitor, quite often a PDL1 and a CTLA4 combined together, or very commonly now combined with immunotherapy, so that there's a dual action on treatment for patients being treated quite often with metastatic cancer. They are most prevalently used in the metastatic and increasingly so in the adjuvant setting following resection surgery. But neoadjuvant treatment is becoming also quite prevalent, particularly in melanoma and ongoing in lung. These drugs are also particularly useful for drugs that are not particularly chemosensitive, such as melanoma or renal cancers. And as you can see here, there's ongoing trial investigations into the combinations with immune checkpoint inhibitors with other drugs, such as other immune checkpoint inhibitors, target therapy, and radiation therapy. So back to my case of my nice gentleman, was doing extremely well, had an almost complete pathological response within 12 months of starting 2-weekly nivolumab. However, in January of this year, he presented to the emergency department with a 4-week history of shortness of breath and exertion and a new oxygen requirement. His CRP, serum reactive C protein, was markedly elevated. On investigations, his CT thorax showed multifocal, patchy, and predominantly peripheral infiltrates bilaterally, and he underwent a bronchoscopy which showed normal findings with no infectious cause. So he was started on IV methylprednisolone with IV antibiotics, and his, unfortunately, blood sugars increased on the high dose steroids, so tight glycemic control was required, and he had an admission of 20 days before being sent home on a tapering dose of steroids. So what was this? So unfortunately, the immune checkpoint inhibitor and immunotherapy drugs have their own set of unique side effects. So unlike chemotherapy, they don't cause nausea, they don't cause systemic symptoms, but they will often cause a unique set of inflammatory symptoms due to T cell dysregulation. And we call these usually immune-related adverse events. These can be quite challenging to differentiate as they can affect any system in the body. So colitis in the GI system, gastrointestinal system, hypopoiesis, so significant endocrinopathies, rash, or hypothetically can affect any system in the body. These can also be quite challenging to differentiate as the underlying pathology is usually the same as a non-immunotherapy induced toxicity. So rashes can occur for other reasons besides immune checkpoint inhibitor, other drug changes. So trying to differentiate and treat this appropriately can be very challenging. And there is significant risks in the use of these drugs. It's been found in trials that more than 50% of patients treated with a PD-L1 treatment develop some form of rash in varying severities, while pneumonitis, which my nice gentleman was suffering from and started on steroids for, is the number one fatal toxicity in PD-L1 monotherapy, while myocarditis is the most fatal toxicity of a combination PD-1 or PD-L1 CTLA combination therapy. Hepatitis or cholangitis is also a common toxicity of immune checkpoint inhibitors combined with targeted treatments. So there can be serious side effects and risks with these. We try and mitigate some of these risks by doing a full history of comorbidities up front and trying to quantify the risk in giving these drugs, but it's often quite difficult if a patient has, say, a previous transplant or a previously known autoimmune condition. Full workup, including, there should be more details on the TSH and FT there, but the thyroid function, cortisol function up front, and glycemic index are checked for a baseline and monitored throughout treatment. A viral screen is always done up front, and then risk stratifying blood tests such as ESR or if patients at high risk of other dysfunction, specific investigations regarding that. So in order to guide the diagnosis and treatment of these, there's a number of different guidelines, but most commonly in Europe, we use the European Society of Medical Oncology guidelines, which gives an excellent breakdown of the common toxicities, diagnosis, and treatment and follow-up. These are developed using data gathered from a large number of clinical trials, which have been ongoing since the first approval of these medications. This is a list here of some of the early trials that were done in non-small cell lung cancer using a range of different immune checkpoint inhibitors compared to other treatments. But as you can see, there's relatively high grades of ongoing toxicity, and for a number of these drugs, grade 3 to 5 immunotoxicity, which are high and severe levels of toxicity, are evident across all trials. One of the most interesting and unusual things about immunotoxicity is they can really occur at any time. Some patients can get severe toxicity after only 1 or 2 doses, while it has been noted that patients can develop immunotoxicity symptoms months after their last dose of treatment. As you can see from the time to toxicity here, the range can be up to 127 weeks recognized in pneumonitis, 130 weeks in endocrinopathies, and 107 weeks in gastrointestinal. So once a patient has received this treatment, there's no real time when they're hypothetically out of danger to develop these, as far as we know, although obviously given the newness of these drugs, this advent is still being followed up. The structure of the ESMO guidance helps to diagnose and grade the immune-mediated adverse events, ruling out different diagnosis, selecting the appropriate immunosuppression strategy for higher grade events, and then evaluation after 72 hours. So the most important thing when it comes to recognizing and treating an immune-mediated adverse event is the grade. So we use the CT-CAE grading most commonly, so the common terminology criteria for adverse events. These are very specific to each system, but on the whole, grade 1 is mild and can usually be treated relatively conservatively. 2 would be moderate, 3 would be severe and would always require hospitalization for supportive care, while 4 is life-threatening, grade 5 is unfortunately death related to the adverse event. And the treatment paradigms and the recognition of these are all dependent on the grade, and the continuation of the treatment is also very dependent on the grade. So this is an example of the pneumonitis algorithm for the ESMO guidelines. And as you see, each section is graded. There is guidance regarding monitoring, diagnosis, further investigations, and then treatment paradigms. The decision to continue the treatment versus hold is very also dependent on grade. And this is also, unfortunately, an issue when patients want to continue on with treatment, especially if they're having a strong effect, like my patient, whereas for their own sake will often have to stop. The cornerstone of all treatment of immune toxicity is steroids, usually high dose, and these can be given 1 to 2 milligrams per kilogram from usually grade 2 and certainly grade 3 or higher. Can be given PO at lower grades, but we would recommend IV and up to 2 milligrams in higher grades and severe. Cutaneous toxicities, as I said, different toxicities have different sections and different recommendations. So could be treated conservatively with topical treatments initially, but then would require steroids further on. And as you see, there's a range of different types of eruptions that can occur with this. Endocrinopathies would often be the exception to this rule, in that patients would not necessarily need to stop the drug or be treated with steroids, as the endocrine dysfunction can usually be managed with replacement of any deficiencies or management of symptoms. Transient thyrotoxicosis is very common, where a patient transiently gets a high T4 level and then becomes hypothyroid and may need thyroid replacement at that point, but rarely do patients become symptomatic enough that their treatment needs to be held, or that they would need to be started on steroids unless having some form of crisis. So my patient, unfortunately, again presented back into the emergency department in March 24 with persistent pain in his upper and lower gums, which were very sensitive to hot and cold. He couldn't chew, he couldn't eat, and despite a course of antibiotics at home, his vital signs were relatively stable, but his temperature was raised. And on examination, he had pus at his gum line with no obvious other form of cause. So on review of his admission bloods, as you note here, he had a raised CRP, but he had an absolute neutrophil count of 0.01, so he was profoundly immunosuppressed. No obvious signs of infection, and no cause of his temperature was found other than his gums and the incredibly low neutrophil counts. So unfortunately, this turned out to be a prolonged neutropenia, which is believed to be secondary to the nivolumab. It's an isolated neutropenia, no other issues with other white blood cells, and ongoing temperatures and opportunistic infections became an issue the longer he continued to be neutropenic. He also had worsening glycemic control and was started on a number of immunosuppressive regimes, including IV methylpred up to 2 milligrams per kilogram, was then started on second-line immunosuppression with IV immunoglobulins and cyclosporin with broad-spectrum antibiotics. And the patient, unfortunately, had a very prolonged admission. Hematology review and bone marrow biopsy showed reduced myelopoiesis, which didn't have any obvious cause, and no other malfunction with the bone marrow. After 5 to 6 weeks of second-line immunosuppression, the patient's neutrophil count began to recover, and with GCF support has then subsequently fully recovered. So rare complications are rare. They're usually between 1 and 5%. Most commonly hematological, such as in this patient, neurological, ocular, or there can be overlap syndromes in particular. Rare complications, unfortunately, tend to be the most devastating. They have the most significant adverse event on patients. They can lose their vision, they can lose movement, they can become profoundly confused or cognitively disabled, and myasthenia, myocarditis, myositis overlap will require ICU admission, and unfortunately has a high level of mortality at nearly 60%. Another form of immunotoxicity similar to this would be refractory or chronic immunotoxicity, such as in this patient, which fails to respond to high-dose steroids within 48 to 72 hours. And at that time, second-line immunosuppression should be considered. Whereas a chronic immune-regulated adverse event is when symptoms persist or worsen as soon as the steroids are tapered, where they get an initial response, but then when tapering, occurs, the symptoms reoccur. The question of whether to resume or to re-challenge treatment after a patient has suffered a significant immunotoxicity is one that is still hotly debated at all conferences. The ESMO guidelines recommend potentially a class switch from between drugs, or a re-challenge with the same class of agent, with very, very close monitoring. Under investigation is secondary prevention, where the immune checkpoint inhibitor is resumed with, let's say, a low-dose steroid for concomitant immunosuppressive therapy, but this is still very much under investigation. Further immunotherapy, the structures of neoadjuvant or adjuvant immunotherapy, TILS therapy, or immune checkpoint inhibitor combinations is still ongoing, and the programming of the immune system is not done. However, within the immune checkpoint inhibitor domain, obviously these immunotoxicities, in particular in the chronic setting, patients will do extremely well from a cancer perspective, will have lifelong side effects, which will lead to them needing support going forward. And the planning around this is going to be instrumental in treating this patient population in the future. So again, back to my patient, after all of his side effects, was it worth it? Well, this is what his neck looked like this week. He's had a complete pathological response. He has no evidence of any remaining disease on scan. And he, despite all the side effects, has done extremely well. So thank you very much for having me today, and I'm happy to take any questions in the following section.
So this wraps us up for the last lecture. Thank you, Carolyn. So we are very happy to have you all on board today here. As you might have noticed, there were some slight technical hiccups. The dog ate one of the videotapes, but it was retrieved in time just before Marcus's lecture. If you would like to ask a question, please feel free to do so. And ask them by text, and we will discuss them here plenary. So we started out with Lawrence, who showed that there may be a lot of potential of drug-drug interactions between DOACs and targeted therapy, and that there may be options to resolve them, but they're currently not always routine practice. Marcus has touched upon the role of therapeutic drug monitoring, and has shown that although it doesn't always have a place, it might have a place to improve treatment, and that the timing is right, especially considering the FDA is being really assertive and proactive in getting personalized dosing to the clinic and into the registration dossiers. And Carolyn has touched upon the immune-related side effects. So if there are no questions yet from the audience, I would really like to start out with asking Caroline. So, what do you think? Should we really prevent immune-related toxicities, or may it also be a sign of efficacy of treatment?
So I apologize now if I pitch this slightly low. I was told to go very, very basic in it, but I think I'm teaching an awful lot of things you already know. So my apologies if that was a little bit too basic. But it's very difficult to tell. Like I've seen an awful lot of patients on these treatments, and for this patient, he'd had nearly 2 years of treatment before he developed serious immunotoxicity side effects. He then developed what turned out to be a chronic pneumonitis with ongoing symptoms for nearly 2 months. And then just as we felt like we had gotten on top of that, he then developed this isolated myelosuppression with a neutropenia. And ourselves in the hematology team were trawling every case file on the internet that we could find. It's a very, very rare side effect. And we still don't really even understand the pathophysiology of it. So, of course, the big question is, if we'd stopped his treatment at 24 months, the way an awful lot of the trials did, would he still have developed these treatments, or would he still have developed these side effects, or was this always going to happen? You know, the myelosuppression happened 4 months after he'd had his last dose of immune checkpoint inhibitor, so it was obviously still an ongoing significant immuno response. It's taken 3 lines of immunosuppression in order to improve this, and he's still on cyclosporin. We've taken him down off the steroids, but like everything, we're now concerned we start titrating down the cyclosporin, we're going to end up back where we are. So it's a very, very very difficult thing to balance. But again, you look at the significant response that he's had. It was very, very difficult for us to make the decision to stop treatment when he was having such a good response with the risk of it coming back.
Well, Rob and Caroline, I mean, this is a fascinating discussion, because if you think chemo, you know, the bad chemo that is so toxic, and then immunotherapy, which everybody said, well, this is fantastic. It has such a good tolerability, and now the field moves a little bit, and I hear more and more people say, well, but you can have this very nasty, unexpected, unpredictable toxicity. Yeah, so I think
and there was one slide that was missing earlier, but obviously in the context with the previous lectures on osimertinib and various treatments, obviously some of the trials that have been ongoing combining immune checkpoint inhibitors and targeted treatments have massively increased the toxicity, particularly pneumonitis and hepatitis. So there's obviously a lot of concern around the levels of toxicity, particularly with other drug interactions.
I would, if I may ask Lawrence, you showed you gave a nice overview, and I always realized that we are preferring usually apixaban to the other NOACs, and I always thought this is probably because we just have the best data, and I think I heard this also from your talk, but it seems that this is not the only reason, but one other reason is the pharmacological aspect. Is this correct?
If you take a look at all the clinical,
I would say yes, we should prefer apixaban, right?
From a clinical point of view, if you take a look at the clinical trial data, on the one hand, then it paints quite a convincing picture. We have sound safety data across like all indications, from little kids to old people with AFib, with VTE, with cancer, without cancer, with people who weigh a little bit too much, people who are underweight. There are quite reassuring data for apixaban. For sure. It has multiple escape mechanisms, which means that it's quite nicely protected against many drug-drug interactions. But if you then take a look at also clinical trial data about the pharmacological profile, and you bear in mind the potential for drug interactions, then for sure edoxaban is the clear winner. It seems that you see that a lot with if there are several consequent classes or consequent drugs within a certain novel class. Dabigatran, they were first. They made some mistakes is a big word, but they made some small mistakes, and then rivaroxaban they learned, and then apixaban learned a little bit more, and then edoxaban, how they performed their trials and how they chose their endpoints in AFib, in their landmark trials, means that they were smarter with their dosing and dosing regimens. They take into account weight, renal function, co-medication, which means that you can enrich those trials. So in this specific setting, from a drug-drug interaction potential, and this is something that we see in our oncology patients as well, we see a rapid increase of the use of edoxaban. But apixaban and edoxaban for sure are the number 2 drugs, much more than rivaroxaban and dabigatran. Yes.
Thanks.
Marcus, I was wondering, could I ask you, so we're not doing levels at all in EGFR, and especially with osimertinib and things like that. Would you have recommendations around, do you think there's certain patients we should be checking levels on, maybe higher risk patients or patients who are having side effects that we should be focusing on in order to, if we were going to start doing this here?
Yeah, thanks for the question. I in fact realized also when I prepared this talk that I think we should differentiate more between, we are always thinking, well, we should do this systemically in all patients, but maybe it would make sense to think more about opportunistic, again, patients with toxicity, where you might feel more relaxed to down dose. patients with organ dysfunction. But yeah, I think TDM questions that come from clinical situations probably make a lot of sense. But I mean, the elephant in the room is, of course, how much evidence do we need to really make more broad recommendations, and that's really difficult, because the official statements from many experts, not necessarily in the cancer field, is that you should show improved activity, and I think that's not realistic in the oncology field. And it's very difficult to run randomized trials. Very difficult.
But from a clinical point of view, it would be a huge benefit to us if we had a patient, let's say, who was struggling on it, that we knew maybe they didn't need the 80 milligrams, and you know, they could do quite well on 40 and minimize the side effects that way.
Yes. Yes. I think there is no easy solution for that.
There never
but it's
is.
interesting to see what FDA discusses, and now also EMA, which puts the drug optimization a little bit more into the forefront. I mean, it's not new, but I think it gets more awareness, and I think probably for that it's good times to come together and push this.
So, Marcus, are you saying that that there should be a culture change rather than an evidence change?
Well, you know, the problem is that the pharmacology community tends to discuss within their community, and everybody says, well, we have to do that. But in the end, you have to convince the clinicians, right? And the clinicians tend to find a new drug more sexy than to optimize old drugs. I think that's the basic issue, and the other issue is that we tend to run behind, you know, the approvals and the changing treatment algorithms. And for this reason, it's very interesting to see that the approval agencies that discuss and think about, you know, making maybe conditional approvals with recommendations to the manufacturer that they should do certain, you know, optimizations. The other question is whether academia really can jump into this situation and really do those trials. I'm not so convinced about this, because manufacturers probably tend to do these optimization trials by themselves. Yeah, but still, I think it's a good and important discussion.
And this touches also a little bit on the subject of Lawrence, who has discussed TDM of DOACs.
Yeah.
So is there really evidence or not?
I wish to not touch that topic like with a 5 feet pole. Is there evidence that it's there? If we're honest and we take a look at how the studies were done, and that's then the if we want to see randomized controlled trial data where they compare strategy of monitoring and dose adjustment versus the fixed or stratified dosing that we see now in clinical practice, then no, we do not have those data. That being said, they did use and check. They used models and the verified exposure of DOACs in the cancer VTE setting in the pediatric indication. So it's not that the companies cannot do it, but it feels like they don't want to do it, because then they have the label that it's a drug that you have to monitor. And the entire sales pitch of the DOAC is that, well, it's just heparin in a pill. It's the warfarin killer. And warfarin, it's a narrow therapeutic index, and you have to monitor it. You have to systematically monitor it. And now you don't have to. And now that the detox spirit of monitoring has has been completed. Now we see that we are confronted with many patients that were not included in those trials. It's not like that we have a lot of data on AFib, the use of DOACs in AFib in patients with advanced cancer. It's that were not enrolled, so it's always a guess, and so we can choose to play the guessing game. I suppose that's the pharmacology team setting, and then we're going to interpret the data, and then someone is, and we're going to do some post hoc or academic or phase 4 studies, or, and I suppose that makes most sense, that FDA and EMA demands more data from the involved companies. Yeah. Otherwise, we'll always be one step behind, and we will be using drugs, and we won't feel that comfortable, I guess. Exactly the same now with the mavacamten story. So first TDM, and then the FDA went for, well, drop TDM, and now you can just check LVOT and injection fraction. And EMA, no, you have to do CYP genotyping. But we do have, like, the TDM was dropped there very explicitly, actually, by the company. So I'm all in favor, actually, of motivating the companies whenever they file for an application for a new indication.
But this is a very political answer, and I know what you're really thinking. But this we have to. I think we have to end this discussion because we're in time. I would like to thank all speakers today: Marcus, Carolyn, Lawrence. Thank you very much.
Thank you.
With that, I would like to conclude today's webinar. So with that, we're closing the webinar, and I think the next slide will be on the people who have supported us and advertised us. Please participate in the post-webinar survey, not only because you will help us and help us improve the next webinar, but also you will receive a certificate of attendance for your continuous medical education, and you can send it to your own organization. All the materials shown here will be provided, provided that speakers have provided their permission, and they will be available on the Academic Medical Education website. Lastly, we would like to again thank Longkanker Nederland and longoncologie.nl for endorsing us. It really helped us. So on behalf of everyone today, also myself and Marcus, thank you very much, and we hope to see you next time.